question has arisen of whether when we appear to have removed all of the polyp, that is, we have snare resected all the visible polyp that is there. If necessary, if there was some flat or fibrotic tissue, we have performed avulsion. But we've reached the point where we cannot see any residual polyp. It looks like we're done. So the question now arises, are we done? Or is there something else that should be done to try to improve the outcomes? And one of the outcomes that we definitely want to improve in EMR is to try to reduce the recurrence rate. We usually, after performing a piecemeal EMR, will bring the patient back for another colonoscopy, another examination in around 6 months would be typical, 4 to 6 months in that range. And we're going to examine the scar and see if there's any residual polyp. If we have a rate of residual polyp that's in the order of 15 or 20%, we're doing pretty well, but why not get better? Why not have it even be lower? So a concept that people have discussed is we reach that point where it's all resected. Should we now go around the perimeter, right on the margin of normal tissue and submucosal defect, and burn that area up? An old study using the argon plasma coagulator showed that if we did that, it actually did reduce the recurrence rate. Recently, we've seen a very large study from Michael Burke's group in Australia in which treating that edge with the snare tip set on soft coagulation current produced about an 80% reduction in the recurrence rate. So the paradigm of EMR now is snare resect all of the visible polyp. If there's some portion you can't get because it's too flat or fibrotic, avulse it. Now when the polyp is entirely removed, rather than quitting, take the snare tip and burn that entire edge, and that completes the EMR.